So I'm actually going to talk today about the psychological impact of PCOS, and I'm talking to you based as a clinician, so I see a lot of women with PCOS, not so many nowadays given I have a number of other different hats, but and also a lot of what I'm going to talk about is based on the research that we did in the research unit, and which has continued actually to still be very relevant. So I was part of a very large study that looked at the psychological impact of polycystic ovary syndrome, and also things like type 2 diabetes, pre-diabetes, gestational diabetes, on lifestyle-related behaviour and things like body image, anxiety, depression. So you'll see a mixture of different bits of research that Jean Hales has actually conducted. Probably the thing that I would like to say is that it is a really complex condition. It's complex for every individual woman. I think really it's a bit like menopause for me. Every woman has her own experience of PCOS, and I think we need to remember that it depends on the clinical features that each woman may actually end up with. Without a doubt, there are higher rates of anxiety and depression, and we'll have a look at some of the research around that. But it's really around this sense of control that's been taken away from women. They don't feel they're as in control of their bodies when it's behaving in a way that they may not be able to predict. And that has a big impact on relationships and family and job and their health-related quality of life. And I was also very lucky to chair the emotional wellbeing guideline group for the polycystic ovary syndrome guidelines when we did them. And again, that still is incredibly relevant. And what came out of that for me, and still is very important, is that we must do some kind of psychological assessment of a woman if she comes to you and you think she has PCOS. Rosie alluded to the different criteria that has been used to decide if a woman has PCOS, and she put up the Rotterdam, which is the one that we would use in any research. But what's really interesting is that other studies use different criteria. So we're actually looking at studies that may have women who've been diagnosed under NIH criteria or the Androgen Excess Society criteria. Most of the research now does look at Rotterdam, but it does actually impact on some of the findings, and so I can point that out as we go. I mentioned that it's complex, so it's really around the different experiences that a woman might have. Whether she is a lean PCOS woman, if she has put on a lot of weight recently, if she's changed her diet and it's just not working like it used to. There's also, regardless of whether PCOS actually impacts significantly on fertility, there is the notion of infertility and the stories that are out there. There's also the risk of future health problems, which Rosie talked about. I mentioned the high incidence, and it is actually very high, but it's becoming also an economic burden, personally and for society. Rosie again talked about, you know, the different treatments that women might have, and laser treatment is very, very expensive, and if it doesn't work and it takes a long time to work and you don't see results, it can be incredibly frustrating and actually very distressing. So one of the things that Jane Fisher talks about, who heads up the research unit now, she says if you don't have good mental health, it's very hard to have good physical health. And that's where this is a really important notion to think about when you are asking women to make lifestyle changes. It's hard when you're anxious and you're depressed and you feel like something else is in control of you. I thought I would read about Jane, and Jane was actually one of our research participants, and she wrote to us, as did many, many women who were part of the study, and she opened up her heart. And so she said, "Dear Mandy, where do I start? I didn't get regular periods like everyone else, and my doctor kept telling me that was normal. And after a few years, I would get a regular cycle. Then the acne really took hold, and it didn't matter what I did, I couldn't get rid of it. My poor mum must have bought every product out there, but I just didn't feel right. I would get very anxious easily. I couldn't eat the same foods as other girls without putting on weight. And once the excess hair growth on my face and body really took over, and I mean really took over, that was the end of the beach for me. I was 15. 10 years later, I was diagnosed with polycystic ovary syndrome. Mainly, it has impacted my self-esteem as I feel overweight and still worried about acne. I have a very restricted diet in terms of calories, which stops me socialising at events, which include eating and drinking, so no dinner with friends. I constantly think about food and force myself to go to the gym and work out hard to try to lose weight. Sometimes I feel like I get on top of it and I begin to lose some, and then the next week, if I don't exercise or I eat a tiny bit more than normal, it all comes back on. I'm really struggling to lose weight to get to a body shape I'm comfortable with. When I feel fat, I do not go out. If I do go out, I normally feel very self-conscious. It's frustrating. I eat better and exercise more than my partner and friends, yet I am still large. My husband and I have been trying for 2 years to fall pregnant. We've had 3 miscarriages, but have not been able to fall pregnant again. My obstetrician's only advice is to lose weight. Arg, a very unhappy smiley face. Clomid has been discussed, but he thinks I'm too young and possibly could increase my risk of ovarian cancer. I feel with my weight that everyone is judging me and think that I must have a bad diet or exercise levels. There is limited information on PCOS. Guess what? I'm a med student, so I have lots of access to information, but even within the medical community, there is a lot of misinformation. I'm now considering lap band surgery as I don't know what else to do. So that was Jane, and you know, as anybody when you get a letter like that, and as you would know when you see the patients and the clients that you do, it's incredibly frustrating because you want to help. So, what are the issues that contribute? And Jane actually talked about the 10 years for diagnosis. There's something like 61% of women take longer than 12 months to be diagnosed with PCOS, and when they are diagnosed, the experience is very dissatisfying. Only 48% were actually told or given information about PCOS, and they found that actually quite dissatisfying. They were less confident to get information, they were less confident to manage the disease and make the lifestyle changes, and it had a huge impact on their body image. Let's have a look at anxiety, because what we've found in the research is that there is a significantly increased prevalence of anxiety. So in the studies that we've done, we actually found that 57% of women had anxiety on the continuum. 19% of those women had severe anxiety and constant panic attacks. If you look at the general population of around 18%, which is still actually very high, you can see how it really impacts. I think also that impaired quality of life which comes with it, and often we have a lot of comorbid depression, and there are enough studies out there now to show that this is a consistent finding. In terms of depression, the range of some of the studies, and when you look at the studies are whether it's NIH criteria, whether it's androgen, whether it's Rotterdam, but probably if you took an average, it would be sitting around that high 30s, 40% of women with PCOS having depression, and that's compared to 7%. It's an increased severity as well and a high conversion. So if you think about it, it takes a long time to the diagnosis, that opportunity to get more and more distressed starts to take hold. And we do know one of the first pilot studies that we did in the research unit, we found that women who were struggling with fertility were more likely to be depressed than the other women. We've used the hospital anxiety and depression scale in a lot of our research, and I know that a lot of doctors also use it. It's quite a quick, it's 14 items. It's very good at categorising along the continuum of mild, moderate and severe. And what we found in the study when we compared women without PCOS was that there was a significantly higher level in that severe category and in the moderate category for anxiety, and then also really for depression. I put fertility up there because it is part of setting the scene for mood. So if we have an adverse reproductive profile, where a woman comes to you and she's got menstrual irregularity, perhaps she's compromised fertility, maybe it's like Jane and she's taking a long time and she's had a number of miscarriages. There is in the research a number of different effects from a psychological point of view for women who go through this sort of journey, if you like. There is a higher risk of preterm birth, a higher risk of perinatal mortality, postnatal hospitalisations and adverse health outcomes for babies. And also women with NIH PCOS had poorer infertility-related quality of life. So that was the one that had only the two categories compared to non-NIH PCOS. And also there was an increased miscarriage and adverse obstetric outcome in Lisa Moran. Lisa Moran was part of the research unit for a while and has done some really significant research in the PCOS field. Not only, she's actually a dietitian, but she and I did a lot of work on psychology, particularly in adolescence. We also find that women with PCOS are less likely to use contraception because they've been told that they may have problems. So they've heard this story. I had one woman who came to me once and she said, my greatest sadness is I will never be able to have children. And I was like, what is there, can we unpack that and go through that? And what have you been told? And she said, I was diagnosed with PCOS, so I know I can't have children. So it's that misinformation, it's the stories that are out there. And that was a doctor actually in another country who told her that. And so once, we sent her off and she got some of the information that it might actually be okay, that there is hope out there, and that's one of the things, generating hope, that helped her enormously. But if you walk around and don't see the right people and don't talk to the right people, you live with that story and think that it can't happen. May not be on contraception, so it might also be that you fall pregnant and you didn't want to, and that happens too. We know that BMI also impacts in terms of pregnancy, and women who do lose weight tend to have better profiles. As Rosie talked about, that 5 to 10% weight loss can kickstart ovulation, and just telling women that message just brightens their day. And 5% seems kind of manageable. It's not a massive, you've got to lose the 20 kilos, the 50 kilos. It's just a percentage. We know that, again, from the Yoham study was a large community study, that PCOS women are more likely to have infertility treatment and greater use of fertility hormone treatment. Obesity, another setting the scene. So not only does increased adiposity exacerbate the reproductive and metabolic features, it also has an impact on the psychological. Weight loss improves the physical, and it does also improve the psychological, although I would couch that in that there is the context of a woman's life as well. There's worsened health-related quality of life, anxiety and depression related to BMI and weight for NIH PCOS studies. So again, that more severe category. I think there are lots of ways we can look at this. So it's the psychological implications are anxiety, depression, perhaps that social dysfunction that Jane talked about, not wanting to go out and eat with friends, not socialising. And, what does that do? She stays home. She doesn't then face her fears, if you like. We already know that she's anxious. That builds the anxiety, and perhaps that starts that path maybe to agoraphobia or some kind of heightened sense of anxiety. In women who do lose weight, often we find that their psychological profile improves. So it's really that importance of mood as a predictor, as well as looking at that link. If a woman has good mental health, She is more likely to have good physical health. She will want to go for a walk. She will want to actually look at her diet and eat and put herself first. You know, often a lot of women say, well, it's hopeless and I don't really want to even think about it, so I'll just eat whatever. So if we can get that mood also positive and supported, that can help turn those lifestyle messages around. And then there's that whole path of mood and emotional eating. So the more emotional you feel, the more you reach for the chips and the chocolate and all of those things. We had body image is a bit of a fascination of mine, and I looked at it at menopause, and I really wanted to look at it in women with PCOS as well. And women with PCOS have higher body dissatisfaction scores. It does seem to be associated with depression and also a greater BMI. But I thought this was an interesting breakdown. We talk about body image, but what does it really mean? There's a really good scale called the Multidimensional Body Self-Relations Questionnaire, and it's got 10 subscales, and they ask questions about appearance. How do you think and feel about your appearance? How important to you is appearance? Your health, your fitness, your body areas, so you know, anything from the tummy to the hips to your hair to your ankles. So looking at the different parts of the body. And you can see on most of those scales, so this is comparing women without PCOS with PCOS. You can see that on a lot of those subscales, women with PCOS are more dissatisfied with their body image across a whole range of domains. Then we broke it down into BMI, and we looked at BMI, and we've got it, you can see the sort of lilac-y purple is women with a BMI less than 27, and the pink is the women with a BMI which is greater. And women who are leaner have a lot higher satisfaction with their body image. So they feel better about their appearance, they feel better about their health, they feel better about the different body areas, and they also feel better about fitness. Interestingly, no difference in weight. And I think if we went out and did a bit of a vox pop in the street, we would find that most women are also preoccupied with their weight. So no difference there. And I often think, you know, there's a question in your quiz around body image and, you know, do women have more negative body image? We know from general statistics that about 66% of women are very dissatisfied with their body, regardless of what condition they have. But then when you separated it out and you see that women with PCOS have a lot more negative body image than that, then we're really ramping it up. So what does that do? It is about self-efficacy. It is about confidence. You know, it is about that ability to seek help and to get the support that you need. And we know from research again that women with an increased BMI are actually less confident in their ability to manage their disease or participate in social activities. They would not be the little pussycat sitting there. There's a self-efficacy scale we used, which was asking women, you know, how confident do you feel to actually manage your disease? How confident do you feel to talk with your physician in your social activities and to get help? And again, splitting it into BMI, we find that the leaner women with PCOS have more confidence. I'm probably telling you something, you know, nothing you wouldn't really think about or know. But it's interesting when you can see it's about managing the disease and the social activities, and that has an impact down the track. Rosie talked a lot about, you know, testing for diabetes and looking at the future health complications. This data comes from a study that Lisa Moran and I did in adolescents, so adolescents aged between 18 and 24. And we asked them, do you think that you are going to perhaps get gestational diabetes, type 2 diabetes, metabolic syndrome, and we had it all defined for them. Are you worried about infertility? And for the women with PCOS, you can see that they are significantly more worried about being larger, about pre-diabetes and about infertility. Interestingly, gestational diabetes wasn't really on their radar, and even in the conversations that we had with them. So that was an important message for us to communicate. What about fears of future health problems? So not just that you're at risk of something, but when you're older, do you think that something may go wrong because of your PCOS? And we found that, again, women were worried about weight gain, but they were worried about loss of femininity and loss of sexuality. They didn't feel very sexual, they didn't feel feminine. It was very hard with a lot of the hirsutism and the symptoms that they were experiencing. And again, the story of infertility. So they were fearing for their future. What about sexual function? The research is quite interesting. Again, it's a bit hard to come to a conclusion because the researchers will use different scales that ask different questions of different groups of women with PCOS, classified by the criteria. If you looked at a bit of a summary, women with PCOS were more likely to evaluate themselves as worse for arousal, lubrication, satisfaction, pain, and total sexual function than controls. And then there was that finding of they didn't feel they were as good a sexual partner as controls. It wasn't as negative in lean PCOS women. And one of the bits of information which we haven't actually published, so I've put it as unpublished, was we found no difference for things like sexual feelings, responsivity, libido, partner problems. However, we did find that women with PCOS reported more dyspareunia and a lower frequency. So they did find sex more painful. And regardless of, what the findings are, it's an area that needs to be investigated and thought about and discussed. And it's really hard when women have got all of those other symptoms going on for them and they feel uncomfortable anyway, but I would encourage you to have the conversation. So, PCOS can mean decreased quality of life, increased prevalence of and severity of anxiety and depression, greater distress around body image, lowered confidence to manage the disease, immediate concerns over perceived weight gain and infertility, increased psychosocial distress is associated with greater BMI. Some of the younger women do have fears for their future health and potential changes to sexual function. And the question was asked around menopause, and we really don't know very much about PCOS in menopause. So there's now going to be hopefully a lot more research into that and what it actually means for older women. We, again, unpublished, but I took this data out because I think it was quite interesting. We asked women about management and treatment, and we said, how confident do you feel in managing your PCOS if you were to use medications? And then how confident would you feel to actually manage your PCOS with lifestyle? Because the message, and at Gene Hales we give it, the message we give is that lifestyle is really important and please try that first. But if women don't feel confident to do it, they won't necessarily try it. So interestingly, and this is the largest study of 177 women, they really feel that medical therapy, they were extremely and very confident that medical therapy would improve symptoms, it would help with weight loss, and it would prevent complications. They were much less confident around lifestyle. So they were only slightly confident and not at all really around the improving symptoms. Weight loss, much more difficult, and preventing complications. So while we give the message, we also need to talk about how confident do you feel and how can I help you be confident to make those changes. I've mentioned good mental health will aid management, and perhaps it's about a mental health plan for women with PCOS. Education obviously will improve and help significantly. There have been some studies around motivational interviewing. Cognitive behavioural therapy, I'm very eclectic, so it's really around the woman who's sitting in front of you and what will help and what will work best for her situation. And maybe it's just about some problem solving and solution focused, and referring to the right practitioners. The alternative is we also have on the Jean Hales website now the Anxiety Learn Think Do portal, and there is a section for chronic illness. So you can see that there's a special part in the chronic illness. Because I actually had a lot to do with the anxiety portal, and because I have had a lot to do with PCOS, there is a fair bit of information in there that relates to PCOS. So if you have any clients or patients with PCOS, it's somewhere they can go. They can do a self-assessment, they can actually download it, and they could actually bring it into an appointment with you. So it leads you through, it's really the journey of anxiety, and it will actually help them understand where they're at and then what they can do. There are videos. There's also some podcasts in the different life stages and over that chronic illness. And then there's a separate toolkit for each of the areas as well. So everyone's different, and women can find the different things that might suit them, just even to start the conversation. So my take-home message is PCOS is very confusing. It's confusing, certainly I'll put my hand up for me as a practitioner. It's complex. It's controversial for some people, it's costly, it's compromising, and it actually requires great care. And I just wanted to end with, please remember the psychological. And that's all from me.